Yeah, very many thanks to Dr. Golding for taking the session today. So Dr. Golding is a health psychologist whose research interests lie in the areas of public health, health-environment interactions and sustainability, and that's both in health systems and in wider human endeavours. Her PhD research, which was funded by the Economic and Social Research Council and co-supervised by a psychologist and a farm animal vet, used a mix of social science methods to examine the concept of antimicrobial stewardship and beliefs about antimicrobial resistance amongst farm animal vets, farmers and vet students. Dr. Golding's passions lie in applied health research, and she enjoys working on projects that involve collaborations with colleagues from outside academia, as well as academic colleagues from other disciplines. In her current role as a research fellow at the University of Surrey, she is qualitatively exploring how the national COVID-19 lockdowns and travel restrictions across England affected people's relationships with the natural world. This study is part of a larger ERSC-funded project that is being conducted in collaboration with Natural England. Dr. Golding is also involved in two research projects based at the University of Winchester. One is a collaboration with a county council and community organisation to explore people's experiences of volunteering during the COVID-19 lockdowns, and the other is a collaboration with an NHS hospital trust to examine men's treatment decisions for lower urinary tract symptoms. And with that, I'll hand over the floor to Dr. Golding.
Wonderful. Thank you, Claire. And thanks to Claire and Matthew and Ryan for the invite and for having me here today. Yeah, and as Matthew says, I was part of the wider PhD cohort, but I did join the very first training session in Bristol, or the training weeks are in Bristol, and it was absolutely fantastic, brilliant experience. And it's a great initiative, I think, to bring everyone together and encourage the kind of cross-disciplinary conversations. So within that spirit, today's talk is going to be focused predominantly on my PhD work, which was a psychological exploration of antimicrobial usage, essentially, in livestock farming and what that means for antimicrobial stewardship. So today I'm going to talk through, quite a high level about my PhD research, and then just spend 5 or 10 minutes at the end talking about the different postdoc roles that I'm working in right now. So where to start? Oh, here we go, bear with me. There we are. So health psychology, just for those of you who are not social scientists on the call, or even if you are and you're a psychologist, some people, health psychology is a smaller subdiscipline and people often aren't aware of it. But essentially, psychologists are interested in the individual and what influences their thoughts, their feelings and their behaviours. And health psychology takes that and applies it to health-related behaviours and health outcomes, both physical and mental health outcomes, but often physical. And so we look at how what we do in terms of, say, smoking or exercise or taking drugs or whatever it might be is influenced by sort of individual and interpersonal factors such as knowledge or emotions, the people around us, our social norms, our culture, and so on. And it's situated originally in this kind of biopsychosocial model that you might hear talked about, which essentially says that illness, disease, the presence or absence of health and well-being is more than just a function of a kind of host pathogen interaction or about genetics or the absence, sort of a physical, something that's pathologically wrong in the physical body. Illness, disease, outcomes, they're a function of the interaction between the person themselves, both physically, biologically, but also emotionally, psychologically, and also their physical and social environment. So being sick is not just about being exposed to a pathogen or a toxic or developing a cancer, for example. It's influenced by all of these other things, and that's where health psychology sits and what it's interested in. And it's very much a mixed methods social science, so we use a lot of qualitative interview methods and focus groups to talk to people and understand their individual idiosyncratic experiences. But health psychologists also make use of quantitative methods, so large-scale surveys, lab-based experiments and field-based experiments and interventions. And I completed my PhD at the University of Surrey in October. I started in October 2015 and finished in December, and these are my two fabulous supervisors, Jane and Helen. Jane's a psychologist, has worked in health psychology for a long time, and Helen is a farm animal vet. And as I was saying in the chat beforehand, I could not have done my PhD without both of them. It's an interdisciplinary PhD. There are things that we couldn't have done without Jane's expertise, but equally there are things we could not have done without Helen's expertise as a vet. So that's just to give you an insight into where I'm coming from when I think about antimicrobial resistance. So I'm going to assume that most of the people on the call know what antimicrobial resistance is, what it means, but just in case there are some people who are joining for other reasons, social science reasons maybe, or I don't know, you've got a spare hour in your day, that's great. Essentially what we mean by antibiotic resistance or antimicrobial resistance is that the microbes that make us sick have some sense of resistance to the drugs that we use to treat those infections. If we've got a normal, for want of a better word, a normal microbial population, some of them will have resistance to the drugs, some of them won't. In the presence of those drugs, it kills off the ones that aren't resistant, and then it leaves a population of bacteria or viruses that can multiply, and they have that inherent resistance in them. And that makes infections much, much harder to treat. So microbiologists in the room, forgive my high-level simplistic explanation, but broadly speaking, it makes us worry because we can't treat the infections that make us sick. But it's not just about infections. Having access to effective antimicrobials underpins a lot of modern medicine. It underpins everyday things like routine hip and knee replacements, for example, because if you have a surgery, then you're at risk of infection, and we need access to effective antibiotics to make those surgeries relatively low risk. And if you don't have effective antibiotics, then of course we have it changes the risk benefit profile of routine surgeries, but also it underpins things like cancer treatment, organ transplantation, lots of actual everyday sort of things that happen in hospitals and beyond. We just wouldn't be able to do them without antibiotics and other effective antimicrobials. But of course it also impacts the animal population, whether we're thinking about our livestock population or our pets. We all share a microbiome, the bacteria that live on either with or without causing infection. Humans also live on and around other animals and in the environment. And so we need to think about antibiotic resistance as a One Health problem, antimicrobial resistance. This is not just about human medicine, it's not just about veterinary medicine, it's about both of those things, and it's about so much more. It's about environmental science, it's about things like aquaculture, horticulture, how we produce antibiotics and other antimicrobials, and so on. So it's a big complex problem, one that certainly made me hang my head several times during my PhD research. That's an understatement, but it is a hugely complex problem, and we need to think about the use of antimicrobials and all that entails from the perspective of the entire globe. So humans and other animals and the environment, and then also think about all of the different disciplines that have the smarts to offer help in solving this problem. And so where does the psychological approach sit in this? So to me, it's about understanding the behaviour that sits around antimicrobial use. So why do people use them? How do we encourage them to use them appropriately? How do we help them to stop using them inappropriately? And what are the kind of barriers to the desirable behaviours, if you like? And so one of the ways in which this is often implemented is the so-called stewardship interventions. So these are the interventions that happen to encourage doctors, patients, vets, farmers, etc., to change their behaviour, to improve adherence, making sure they finish the course, reduce inappropriate prescribing, don't give drugs that aren't necessarily needed, and also to include better targeted prescribing. So things like using a narrow spectrum antibiotic, so using something that's more targeted and won't have such a broad brush approach at killing or driving resistance in a wider group of microbes. And there's lots of different ways we can do that. Psychologists get involved in stewardship interventions, but we can also think about, for example, economic incentives to change behaviour. And we can also look more broadly, thinking about, do we have effective policies in our health systems and our wider sort of health and social economy? And thinking about responsible use, I took this particular definition for my PhD, but broadly speaking, what we mean by responsible use, what we mean by antimicrobial stewardship, is using essentially the right drug at the right time, at the right dose, making sure it's taken for the right intervals, making sure as well at a global level that the drugs are available for those who need them, that they're accessible, that they're affordable, because we have to remember in all of this talk about using antibiotics correctly, responsibly, etc., they are critical medicines, they're important medicines. We shouldn't be saying we can never use these medicines. We just need to be working towards appropriate use, essentially. And so why did I focus on veterinary medicine? Well, to me, when I first came across the problem of antimicrobial resistance, the idea that we use antibiotics inappropriately, that people take them when they don't need them, they don't take them correctly, etc., etc. This is a classic health psychology problem. People don't do what they're supposed to do in terms of a medication. Let's understand the beliefs, the behaviours, the attitudes that sit around that, and maybe we'll do an intervention with, I don't know, GPs and patients. Perhaps we need to improve doctor-patient communication. This was me very naively doing my master's in health psychology, thinking, yay, there's a nice easy PhD question. Started researching it, thinking about funding applications with Jane Ogden, my psychology supervisor, and yeah, it's been done. It's been done a million times. There's a huge amount of body of work out there in human medicine trying to understand the issue, the thorny issue of inappropriate antimicrobial use. And there's good work out there, large body of evidence, large sort of surveys, lots of interventions, lots of qualitative work, and there's even systematic reviews of systematic reviews in human medicine. In veterinary medicine, it's relatively underserved in comparison. So in early conversations with Jane and saying, oh, it's already been done, you know, blah, 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 it's not really a PhD question. She was like, well, who else uses antibiotics? I was like, I don't know, pharmacists, nurses, vets. And she's like, well, I know a vet. She'd met Helen, who was my veterinary supervisor, who was at Surrey at the time. So we all got together, had a little chat. Helen's focus is on preventative medicine and she's very passionate about AMR already. So that's what we did. We had some conversations. We put together a funding bid and I was very, very lucky to get it. And so that was how we ended up looking at veterinary medicine. And as I say, the existing literature at the time, certainly when I started my PhD in 2015, there was very, very little published. Quite a lot has been published, relatively speaking, in the last few years, which is good to see. There's some momentum growing and that's great. So that was me. That was where I started, essentially looking at, there's this huge body of literature in the human medicine, some of which might be relevant in terms of the broad theoretical things, but in health psychology, we're very conscious that what works in one context might not work in another context. And of course, veterinary medicine, veterinary prescribing is very different to human medicine in some ways, and in many ways they're similar, which I'll come on to later on very briefly. So this was my PhD research. Broadly speaking, I did 3 studies. I started out with some qualitative work, did some interviews to really just understand what vets and farmers are thinking, and I'll share the findings with you. Then I followed up some of those qualitative interview insights in an experimental vignette, which I'll explain what that means when we get there, and also did a cross-sectional survey with vets. And then I finished up with a cross-sectional survey of veterinary students. So study 1, the qualitative interviews. This I like qualitative work. In qualitative work, the place of qualitative work is not to try and generalize. It's not to understand big truths per se, or make any claims about what we found in this sample we can generalize to somebody else. It's more about getting the in-depth individual insights into what people think is going on for themselves, how they make sense of their experiences. So I did these detailed one-to-one interviews with vets and with farmers over the telephone. The vets themselves, they were all farm vets, but they were working in a mix of different practices. So I think one was a specialist pig vet, but the others were kind of either working across different ruminants or were predominantly cattle, but did a bit of sheep work perhaps. So there was a mix of vet specialisms, but they were all in farm animal medicine. And then the farmers themselves, again, they were a mix. I didn't get to speak to any poultry vets or poultry farmers, but I did speak to farmers who were keeping pigs, cattle of different, dairy or beef, for example, and also sheep farmers. And the broad aim of the study was just to explore what vets and farmers believe about antimicrobial usage on farms. Do they think there's too much? Do they think it's about right? Do they think, you know, what else is going on? What's driving their prescribing behaviours, their usage behaviours? And what do they think about AMR? Do they even think it's a problem on farms, for example? And then I was interested in how these beliefs sort of what all of this meant for stewardship. And so the study itself, we generated 4 themes. So we use an approach called thematic analysis. Basically, you record your interviews, you transcribe them, and then you go through, it's called coding, but you basically go through and you kind of highlight meaningful pieces of text, and then you do the interpretation of what all of these bits of text mean. And I came up with these 4 themes in collaboration with Jane and Helen. And broadly speaking, there's a lot that's similar between the vets and the farmers that I spoke to. This first theme, shared conflict between ideals and behaviour. Vets and farmers know what stewardship is. They know that AMR is a threat. They understand the broad principles of using antimicrobials responsibly. So they know what it means, and they worry about what AMR means for animal health. They also worry about using antibiotics appropriately right now so that animals are not being left untreated, for example. But they are aware that their own ideals do not always align with their actual behaviour. So, you know, the Gavin here is saying, you know, sometimes I have to use them. I don't like it, but you have to, because he's talking about how, you know, he's motivated both to protect the welfare of the animals, but also to protect economic factors related to the farm. And if we think about how, you know, what some of the barriers are for the vets and the farmers, who were very free with me saying, you know, I know I shouldn't sometimes, you know, I shouldn't in certain scenarios, but I do prescribe or I do use. And some of the reasons that they prescribe less than ideally, shall we say, they varied slightly for the vets and the farmers. So there were overlaps, but the vets themselves were particularly conscious of the variability of the farmers they were dealing with. So they would change their prescribing decisions based on who they were interacting with. You know, sometimes they might just prescribe something because it helped to end or resolve a difficult consultation, or maybe they just knew which farmers were more open to a kind of discussion about other ways of managing disease on the farm, perhaps. And vets were very conscious that they were running a business, that they had a business, you know, farmer-client business relationship to protect as well. And this would sometimes influence their prescribing decision. And in terms of the farmers, they were very much focused on the economic challenges of farming. They talked about the kind of, you know, as much as I might want to do certain things to improve animal health on my farm, I'm constrained by costs, or whether that's, you know, cash flow in terms of doing big investment to, say, improve housing, or whether it's just the kind of everyday pressures of cost in terms of the cost of production versus how much they're going to get for their milk or their animal when it goes to slaughter, for example. And what all this means for stewardship is this real sense of ambivalence that vets and farmers express. So they have this shared ownership. Vets and farmers, as I said, they get it. They know they need to protect antibiotics, antimicrobials, in order to protect them for the future. They understand that, you know, we might face a situation where there are no effective drugs to manage animal health, and that has huge impacts in terms of, you know, how do you maintain livestock farming in its current form if you cannot have access to effective antibiotics? That threatens food security and all of these other big, grander social issues that come with it. They understand that. And they also have a desire to be responsible users in order to maintain, for example, the public's trust in farming. A couple of farmers particularly refer to things like BSE outbreak or other kind of high profile, in inverted commas, farming scandals where, you know, it undermines public confidence in farming. And they don't want there to be an undermining of public confidence because the public think that vets and farmers aren't using antibiotics responsibly, for example. So they do take ownership of this issue, but they also engage in quite a lot of other blaming for the problem of AMR. So whichever way you want to cut the pie, wherever you want to look for it, individual vets and individual farmers would say things like, I know I could be better, but I'm doing as much as I can, really. Like, it's all these external factors that stop me doing anything slightly better. But you know what? It's that other farm down the road, or it's that other veterinary practice down the road, or it's not me as a dairy farmer, it's the sheep farmers, or it's the pig farmers, or it's the poultry farmers. So the vets and the farmers were blaming other members of their own professions, they were blaming the other professions, they were blaming people in other industries. And then collectively as a group, they were all blaming human medicine. It's not farming that's the problem. It's GPs just handing them out like sweets, or it's patients not taking them properly, or it's the small animal vets, you know, they're all giving their cats these 3rd and 4th generation cephalosporins, and like, we never prescribe that kind of drug, and all of this. And you get all of these messages coming out. And then you would have people saying it's not even the medicine, you know, it's things like, look at how it's used overseas. In the UK, in Europe, we're pretty good, but look at the massive amounts of antibiotics used in US agriculture, or in places, you know, in other countries in the world where you can just buy it over the counter. So essentially you've got this kind of ambivalence going on where they're saying, yeah, we get it, we know we need to be responsible, but it's everybody else who isn't responsible. And that was really interesting in my study. There's lots of lovely data there about that. But actually, as I continued the literature review, and then as we were writing it up, the vets and farmers in my study are not unique in this. Wherever you look for this kind of other blaming phenomenon in the world of AMR, it is there. Researchers might not have explicitly researched it, but there is this, I mean, some have explicitly researched it, but it's not unique to vets and farmers. Doctors do it, GPs do it, patients do it, everybody lays the greater bulk of responsibility at somebody else's door, which I argue in my PhD and in this talk is part of the problem, and is perhaps an opportunity for intervention, is to try and help people realise that we're all in this together. This is a One Health problem, so let's not make this about other blaming and other groups. So just to quickly wrap this up, broadly speaking, the barriers to stewardship are external, they're non-clinical. Vets particularly concerned about the farmers they work with, and also the relationships that they have with farmers, and they're kind of, you know, these things definitely are playing on vets' minds when they're making their prescribing decisions. Farmers feel constrained by economic and market circumstances, and also by conflicting messages sometimes from, you know, different veterinary practices agreeing or disagreeing on which is the most appropriate treatment. And then social identity processes are potentially at play. Social identity is basically it's an interpersonal theory. It's about how so for example, I'm a psychologist, I have beliefs about what that means as a psychologist, other people will have beliefs about what that means. But broadly speaking, our social identities, our group identities, we internalize rules about what the norms are for those groups, what's an appropriate behavior. So if you think about, you know, a farm animal vet, an appropriate behavior is to treat an animal, but an inappropriate behavior for a vet might be to treat a human, for example. So there's rules in inverted commas. We internalize and make norms around what different groups should and shouldn't do. And I'm not going to go into social identity in any great detail. But it is an important potential psychological theory that's underpinning this other blaming, this, you know, us. Essentially what social identity theory predicts and leads to is that it leads to this us and them mentality that we see in all kinds of areas of conflict in human behaviour. So what did I do next? So following on from that qualitative work, I needed to kind of focus in. I would have loved to have followed this up with vets and with farmers, but we focused on vets. And I really wanted to understand and try and unpick some of the different contextual factors. So these, you know, the situation on the farm, the different variabilities in personalities between different farmers, and also the quality of the relationship between vets and their farmer clients. So I wanted to kind of take that forward into an experimental study, and then also try and unpick in a quantitative manner a bit more about these beliefs about different groups having different levels of responsibility for causing and preventing AMR. So I started out with a very small pilot study, pilot vignette study. And for those of you who aren't familiar with the term, a vignette is basically a hypothetical scenario. So for example, it's a case of you walk onto a farm, there's a sick cow, she presents with these symptoms, what would you do, is the high level example. And in this small pilot study, I wanted to basically test some different clinical scenarios to, one, see whether vets would admit to the fact that non-clinical things are influencing them. There's no point me designing a survey or an experiment if people just give me a social desirability answer. I want them to answer fairly honestly. So really what I was exploring in this study was, do vets prescribe differently in the real world compared to what they know they should do in an ideal textbook scenario where they're only considering clinical information, if you like. So this basically, I presented them with 7 different scenarios, 7 types of sick cattle, and the question was, in an ideal textbook scenario, how likely would you be to prescribe antibiotics? And then the second condition was thinking about your own everyday real world practice. How often have you prescribed antibiotics in the last 6 months? And I wanted to see, 1, if there was a difference, and 2, if there would be a difference between the different scenarios so that we could choose the best one for the larger study. And there was a difference. There was a lovely difference. They admitted it. So this was a good thing. It was a very small study. You can critique small studies, absolutely. I'm open to all of that. It's all written up and acknowledged in the limitations. So it was a small sample, but nonetheless, the effect was pretty robust. Broadly speaking, vets do prescribe more in the real world than they do in the ideal textbook scenario, if you like. So this would suggest that non-clinical things are influencing their decisions. We didn't drill down into what any of that meant, but certainly there is a difference in everyday practice compared to what you perhaps would think you would do from your sort of textbook learning. So so that's the same sort of summary. Across all of the scenarios, vets reported being more likely to prescribe in the real world, and they know, therefore, we surmise that this means their prescribing decisions are not based on clinical information alone. So we took one particular scenario forward. The scenario was a dairy cow that had symptoms of a viral infection, was in a herd that had tested positive for a viral infection. And there is some clinical ambiguity over whether or not you would prescribe an antibiotic, because there's a possibility that she might develop a secondary bacterial infection, but, you know, it's balance of risk. So we wanted something where it was a bit of a grey clinical area, where you probably shouldn't prescribe, but maybe you would, antibiotics specifically. So I ran an online experimental vignette. So this is the experiment. Presented people with the scenario. I'll talk about the conditions in a moment. And I also did a cross-sectional survey. I measured farm vets, their values, and their beliefs about whether they think different groups have more or less responsibility for causing and preventing AMR. And this was a survey that ran for 6 months. And thank you if you're on the call and you took part, because it took me a long time to recruit for this. I wanted more than 100 vets. I really struggled to recruit, but we did our best. So probably some of the study is underpowered, which means we didn't find effects where we hoped to, but that's a methodological issue. We'll come on to that another day. So the vignette itself, as I said, we basically presented these details, this clinical information about a cow who was showing some signs of illness that were probably viral but potentially bacterial, and we asked people, how likely would you be to prescribe systemic antibiotics? That was one treatment option in a list of about 7, so we didn't make it clear that we were interested in antibiotics. We were asking them things like, would you isolate her, would you give her fluids, a particular type of diet, for example. And the farm vets who took part, they were randomly allocated to one of 4 conditions. So in the control condition, they just got clinical information. In the economics condition, there was an additional sentence that suggested the farm was under financial pressure, perhaps couldn't afford, a loss from an illness, for example. In the farmer condition, there was a sentence that said the farmer was under staffing and time pressure. And then in the third condition, there was the relationship condition, there was a sentence that suggested the farmer was a bit grumbly and not that happy with the vet from the last visit. So people were allocated to get all the clinical information, and in the economics, farmer and relationship condition, they had one of these additional sentences. And there was a difference, but it wasn't a significant difference when we ran the ANOVA on this. So in the control and the farm financial, the economic condition, they were fairly likely to prescribe systemic antibiotics, but they were more likely to prescribe them in the farmer and the relationship one but not statistically significantly so. So just on context alone, there wasn't a statistically significant difference there. We also measured beliefs about causing AMR and beliefs about preventing AMR, which is the next slide. So this was just cross-sectionally, and we asked questions like, well, there was a list of questions that, that were about these different groups. And farm vets are the reference group here. So compared to themselves, farm vets believed that farmers, human medics, and the public had greater responsibility for causing AMR than themselves. And in terms of preventing AMR, farm vets believed that human medics had more responsibility than themselves for preventing AMR, and companion animal vets had less responsibility than themselves. And the reason these findings about beliefs about responsibility are important is, this from the qualitative work and from this in terms of believing whether or not you have responsibility for a problem is if you don't believe you have responsibility for it, or you believe the responsibility lies elsewhere, you'll be less motivated to change your own behaviour to do that. Now, what's important and encouraging is that farm vets do, they do seem that they have a fair amount of responsibility. It's not like they're scoring themselves 1 and everybody else 4. So farm vets, it's reassuring. They know they have responsibility for causing and preventing, but just that other groups have more or less compared to themselves. Now, running back to the vignette, as I mentioned, there was no impact of context alone. I also measured values. There was absolutely nothing going on there, and it's a separate story, so I haven't included it in the interest of time. But values didn't affect the likelihood of prescribing. Beliefs about which groups have responsibility for causing AMR did not affect vets' prescribing likelihood. But once we accounted for groups' responsibility for preventing AMR, those beliefs did affect the likelihood of prescribing. And in that regression model, vets who were in the relationship condition were more likely to prescribe antibiotics. What that essentially means is when vets believe that their relationship with the farmer client might be under pressure, then potentially they're more likely to prescribe antibiotics. So what the survey showed was that these other blaming patterns that were identified in the qualitative work was identified. Nothing's confirmed in science, is it? Identified in the survey, in the quantitative work, and that they, there's differences in the levels of responsibility that farm vets believe different groups have, and that relationships are important influences on prescribing, or may well be important influences on prescribing. It's one study, it's fairly small, obviously it needs replicating, but that's where we were at with that. And so then finally I followed up. I was really, again, interested in this responsibility about groups for causing and preventing AMR in particular. So I adapted that and ran a survey with vet students. So I recruited vets from 3 universities, and basically just to assess their knowledge about AMR, their self-reported antibiotic usage, and then also what they believe about groups' responsibility for causing and preventing AMR. And again, because there's lots of surveys about what junior doctors think, but there's almost no survey work, just baseline assessing what vet students, where vet students are at. So, as I said, I recruited at 3 universities, Bristol, Liverpool and Surrey. So if anyone's on the call who helped with recruitment, big shout out, thank you. And yeah, we got quite a large sample actually, of just over 500, well, nearly 600 people, so that was good. And in terms of what we found, self-reported behaviour was pretty good. There's probably some social desirability bias in there. There are a group of vet students and there's a lady psychologist at the front saying, here's a survey about antibiotics. But broadly speaking, they all reported doing the right kind of things. It was questions like, or statements like, do you, how often do you take antibiotics when you have a cold? Do you always finish the course of antibiotics? Things like this. So their self-reported behaviour was pretty good. 1 was the lowest possible answer here. So on average, they're all doing pretty good. In terms of their knowledge is also pretty good. In the thesis chapter and hopefully the upcoming paper, we've defined what we mean by poor, average and good knowledge. I think 7 and 8 was what we considered good. It was a number of statements and there was just a true or false answer. The early years students, which is those in years 1 and 2, had pretty good knowledge on average. The later years students, those who are in years 3 and 4 at Surrey, we only got later years student at Surrey, their knowledge was even better. So that's encouraging. Keep teaching people about antimicrobial resistance. And then in terms of beliefs, we saw the similar pattern to what was in the practice in farm vets. So these are vet students. Because at this point they are just veterinary students, that's the wrong word, they're veterinary students as opposed to farm animal or companion animal. They might have ideas about where they want to specialise, but they haven't specialised yet. So we grouped vets together, and we grouped together animal owners as farmers and pet owners. In the survey that we presented to the students, they only saw questions about 4 groups rather than the 6 groups that we see with farm vets. And again, same sort of pattern. Vets are less responsible for causing AMR than other groups, and in terms of preventing, they're also less responsible than other groups for preventing AMR. But encouragingly, in the later years students, they only see themselves as less responsible than animal owners. Vets see themselves as equally responsible as human medics, whereas the students in the beginning of the course don't. This isn't a follow-up over time, so there could be cohort effects here going on. There could be some other reason why we see this difference. But, you know, potentially it means that as vets progress through their training, they begin to realise their own professional responsibility. That's how I take this finding. Moment of encouragement in a research area full of doom and gloom sometimes. So there we go. So that's pretty much it. Self-reported behaviour is good amongst vet students. Their knowledge is pretty good and improves with time on the course. And they also, like farm vets and like the farmers in the qualitative work, believe that other groups have more or less responsibility for preventing AMR. So this is kind of just adding weight to this kind of othering and this other blaming scenario. So what does all this mean? Across all of the findings, you know, broadly speaking, there's good understanding of what AMR is and what stewardship means, and vets and farmers definitely want to be good antimicrobial stewards, but there's all these non-clinical contextual factors that get in the way. And social identity processes, this group identity, this othering, this us and them mentality may well account for some of the ambivalence that we see towards stewardship. Making sense of this, in my thesis, I used something called the social ecological framework, which I adapted to make sense to a veterinary context. But broadly speaking, what we see running throughout the studies that I conducted in my PhD, but also the other similar studies in the veterinary world, and definitely in the human medicine literature, is there are these different levels of things that influence prescribing and usage decision. It is about the internal intrapersonal psychology, knowledge, beliefs, emotions. People prescribe out of fear of getting it wrong. Fear is a massive driver, but there's other things as well. But we also see the interpersonal psychology, interactions and relationships with other people, whether that's clients, patients, other professionals. Prescribing norms in a practice or in a hospital can make a big difference to what people do. But the physical and the social environment is also important. So practical things like the quality of the housing, the sort of basic immunity and herd health that's going on, but also things like time pressures, economic pressures, the legislation, the country you're in, how well that legislation is enforced, what are the industry norms. All of these things are influencing antibiotic and antimicrobial usage in farming and beyond farming. And so what does this mean in terms of taking this research forward, or implications in terms of interventions for antimicrobial stewardship? It's an if at the moment. I'd like to follow up my PhD research, but we'll come on to that in a minute. I think there's some real opportunity there to explore some of these social identity processes. So trying to emphasise what's called the common goal. We need to see AMR, the problem of resistance, the challenges of stewardship as a One Health problem. We're all in this together. We're not vets versus farmers, for example, or psychologists versus anything else, whatever. We're all prescribers, we're all users. We need to try and emphasise the kind of the commonality of this issue and how we all need to work together to try and reduce the less you other something, the more you take responsibility for it. That can only be a good thing. But we also need to recognise that we need interventions at different levels of the social ecological framework. And there are other different models out there. I've used social ecology. But broadly speaking, the key point is that we can intervene with individual vets or farmers or doctors or whoever. And that's great, and it will have some change, but it will only have limited effect, because we have to remember that people are embedded within these wider social contexts and these wider physical contexts. So we also need to intervene to have, we do need ways to support farmers to make changes to housing, for example, on farms, or have different policies, whether that's within an industry or at a governmental level, for example. And so that's it. That's my thesis in a nutshell. It's quite a big nutshell, but there we are. That's pretty much what I've done. Very happy to take questions on it in a minute. I'm just going to spend a few minutes talking about post-PhD life, because I'm aware that a lot of people on the call are still going through the PhD. Yeah, when I was invited, there was, if I could just talk about what I'm doing now, I kind of think of myself as a bit of an accidental academic, in the sense that throughout my PhD, I love doing my PhD. I really enjoyed the research. Have a lot of cynicism for academic life, shall we say, and I'm constantly ambivalent about whether or not I want to stay in academia or whether I want to go and do research, in public sector or charity or whatever. And broadly speaking, as long as I still enjoy it, I'm staying, or as long as someone fund me, I'm staying. It's fine. So I wasn't sure whether I wanted to postdoc particularly, which is why I didn't write any applications or grants during my PhD. I was just focused on finishing my PhD, and then figured I would see what would come next. And I'm currently involved in 3 different postdoc roles. Again, that didn't go to plan, mostly because something happened in 2020 that I'm sure you're all aware of. But broadly speaking, I was approached by, the first thing I was doing, I was approached by Margaret, who I knew from my PhD. I've worked with her before, to take on this qualitative project, part-time project. The idea was I would take on a part-time role. I could breathe out after my PhD. I could think about whether I wanted to write my own funding applications to extend the PhD or something else. So I did. I started in just before Christmas. I vivaed in January and had just started, January 2020, just started this project. We'd got ethics. Richard is the consultant urologist at a local hospital, and Deborah and Margaret are my colleagues at Winchester. We were all ready to go with ethics, and then COVID hit. The NHS shut down, essentially, except for obviously urgent treatment, and the nation, obviously, I mean, yeah, you're all infectious disease people. I don't need to explain to you the impact of COVID. But the point was, we were trying to recruit people through outpatient clinics for a benign disease. Those outpatient clinics stopped. So my work, I knew the role was still there, absolutely, but didn't know when the project would start again. But the project itself has started again. It started in about October time. We started recruiting, and I'm looking to interview men basically about this lower urinary tract symptoms. As men get older, their prostates enlarge and it causes them problems, but it's a quality of life problem. It's not a threat to life. So there's different medication, and generally not a threat to life. There's different medication and surgical options. None of them are perfect. They all carry their own side effect profiles of benefits, pros and cons, risks and benefits. So I'm doing a qualitative exploration of the issue, really. How do people make their decisions? About halfway through recruitment, and quality of life really is central to the condition. It's set to living with the condition, and is hugely influencing men's decision making. So that's project number 1. That was meant to be just my only project. Project number 2 came along when COVID hit. We went into lockdown. The outpatient clinic stopped. Deborah does a lot of work in volunteering and community work. And so we wanted to know what volunteering during COVID-19 was all about. And so she, offered me this role as a kind of stopgap thing while the other project was on hold. And it was brilliant. I interviewed about 19 people during kind of June and July of last year to understand who was volunteering, why they were volunteering, what it was like, and so on. And I'm currently doing the analysis. We're working up the themes at the moment, but broadly speaking, volunteering was hugely valuable during the lockdown, especially in relieving isolation. There were frustrations, particularly for people who couldn't help because they were maybe vulnerable themselves, like the helpers went to be in the helpees, for example. That's quite difficult for people. But volunteering in all its forms, whether it was like the neighbour care staff, the NHS responders, or doing broader community things, was really valuable for people. And then finally, the final project I'm working on is nature engagement and wellbeing. So this is at the University of Surrey, and there's another 50% role where I'm basically part of a multi-project team. We're looking at how the lockdowns and the travel restrictions impacted on how people engage with the natural world, where they went, what they do, how they go there, and how that impacted on their well-being. It's a large team. We're working with Natural England, and I'm part of the qualitative project, interviewing people, and I basically asked people to share with me their some photographs that represent their relationship with nature before, during and after the first COVID-19 lockdowns. They're long, detailed, intense, brilliant interviews, very, very varied, really varied experiences. But broadly speaking, again, I did my last interview last week, so I'm just about to start the analysis, but there's lots of positive and negative experiences to lockdown. People have found plenty of silver linings in that difficult time from their relationships with nature. So let's just give you a flavour of the different things that I'm doing. I would still be in AMR if I wanted to. It's not a case of done that, so glad my PhD is over, walk away from it. Yeah, love it, I'd stay in it. It's just not the way it's worked out as yet. So, and I'm very fortunate to be doing all of these other interesting things, which as a health psychologist, yeah, is what I'm all about, kind of these bigger kind of public population questions. So that's me. Hopefully that wasn't too bad for time. That's okay. Thanks for listening, everyone.
Thank you, Sarah. That was so interesting, and I definitely took a lot from that, and will be putting other blaming as a code in my research. So yeah, really, really good, really interesting. If anyone has any questions, feel free to put your hand up. There's lots of clapping. I don't know if you can see everyone, Sarah. There's lots.
There isn't. Can I stop sharing my screen and then?
Yeah, please do. Yeah.
Excellent. Have I stopped sharing my screen? Yes. That looks great. Thanks, folks.
I see all the appreciation.
Oh, thank you.
I'll go with the question then, if no one else has one initially. So I was just wondering whether you had any recommendations or thoughts to better prepare vets for the kind of pressures that they'll have ahead, and in terms of empowering them to make better prescribing decisions in the future.
Yeah, that's a big one. I think that in terms of, I think it's about, it's difficult. Okay, my reticence in answering is, in health psychology, we always say knowledge is not enough. Basically, knowledge and education gets you so far, but it only gets you a little long way around it. But what I was going to say is, I think in terms of empowering vets, it's about reducing the sense of blame. Like, you are irresponsible is not a good message ever. It turns people off, and it makes them feel disempowered, because they know that there's all these other contextual things that are happening. So I think, as much as knowledge and education isn't sufficient, maybe just but there is a value, there is a place for raising awareness of this kind of research that says, we know you're not always at fault. And then beyond that, I suppose I don't have specific recommendations because I'm a researcher and we haven't done the specific research, but it is about raising, I think it is about encouraging, it's finding ways for vets to have the more difficult conversations with their pharma clients, especially the pharma clients that are less receptive to change in behaviour, whether it's about doing something preventive like introducing vaccinations or changing feed mixes to improve the health, for example. There's lots of different ways you can cut this. And I think it's really tough because, to me, it is about the individual context. What a vet does on one farm will need to be different to what a vet does on another farm. And so, from a research point of view, that's really difficult because you have to tailor and intervene with individual farms, individual vets, but that doesn't get at the scale of the problem. I'm not sure I've entirely answered your question, but if anyone wants to add or challenge me or add suggestions.
I think you really have, and I was just interested to see whether it echoed my kind of, I'm only in my first year, so whether it echoed my kind of preliminary thoughts on it. That I feel like, say with anthelmintic resistance, I feel like we have defined protocols that we're supposed to do, and it's all very clear cut. But as you say, antibiotic prescribing just can't be like that, and therefore it's going to be so much harder to make recommendations on that. So,
yeah. And even when there are protocols, they're not always followed. And I think when you've got, I guess the opening question should always be why, but not in a blaming sense. So why aren't you following the protocols needs to be framed in a way that is, what's stopping you from following them, rather than why aren't you doing it. Like, it's understanding what's the barrier for that farmer. So if a vet is on a farm and they twig that the protocol's not being followed, that's a good place to start. What's the issue, and what can I do to help you overcome that issue? And I mean, there is research that's coming out of Bristol, definitely. Collaboration is key. Working on this as a shared problem, getting vets and farmers to talk to each other and to co-generate or co-produce is the kind of buzzword that you get in all areas of health. Co-produce, come up with the solutions together so that it actually works for both parties rather than top-down decision making, I would say.
Great, really interesting. I think, Ryan, you have your hand up next.
Oh, hello. Thank you, Sarah. That was a great talk. As somebody who just talks to computers all day, it's always good to hear about actual human beings for a change. So I do appreciate that. So when you were talking about the sort of blame and finger pointing culture, you said that could be a step for intervention. What sort of interventions do you think there are that could reduce that culture?
So in terms of reducing, so there's two parts to that question. Two parts to my answer. One example is the Antibiotic Guardian initiative, I suppose you would call it, that's been around for a few years, and it's basically just getting people to pledge to be an antibiotic guardian in whatever that means for them. So you can sign up as a prescriber or a medical student or a member of the public, and it's kind of open to all, and it tries to use this inclusive or non-grouping language, as in, and then there was an evaluation study of that, and vets found that more acceptable because it wasn't us and theming the problem. It wasn't making it about human versus vet med, for example. But again, in terms of actual impact, not sure how much actual impact in terms of changing behaviour that particular intervention has had, because you literally go online and you click and you sign up to be an antibiotic guardian. And I had that little badge on my signature for a while during my PhD, but fundamentally that's it. And, you know, so that's where the health psychologists come back in to say, right, what is the actual, you know, we can do intervention design, behaviour change, and actually understand, does it impact and change outcomes meaningfully? So that's the first part. So there are some interventions out there that might reduce the other blaming, but whether they actually have an effect on behaviour is a different matter. From the psychology literature in terms of what might reduce other blaming, so social identity theory is a massive part of psychology. I find it hugely interesting. It kind of hurts my brain a little bit sometimes because I'm not a social psychologist. I haven't been steeped in this stuff for years. But social identity theory and group, like othering, is one of the mechanisms that underpins prejudice and group division and tension and social things. And one of the ways that we can seek to reduce or overcome prejudice and othering is through something called the contact hypothesis. And this is where you bring groups together, but in a positive way. So you might bring different religious communities together, or you might bring vets and farmers together to work together, and the idea is that if you do these contact interventions, that they can reduce othering. Basically, it makes that person, so I'm a vet, it makes that farmer into a human being. We're no longer vet and farmer. We are now, I think the phrase I used in my thesis, because I was trying to come up with an overarching thing, we're now professionals who care about animal welfare, if you like. So you kind of have this like superordinate grouping. Doing contact hypothesis work well is, there's lots of critiques of it because it has to be done well, it has to be well structured, it has to be a positive interaction, so people have to be working together for a common goal. Yeah, there's mixed evidence about whether or not contact hypothesis works, contact interventions work in the literature, but broadly that's usually down to how well the intervention has been implemented. So that's the kind of intervention you would do to reduce other blaming. I don't think it's been done in vet med, and I don't even think it's been done in human medicine. So that's, to me, that's an interesting option for the future.
Sounds like there's a grant application in there somewhere.
Yeah, maybe. Yeah, that's the plan.
Cheers.
Hopefully, you never know.
And
Cheers again.
I think Lucy has a question now.
Mm-hmm.
Hi, can you hear me okay?
Yes, thank you.
Okay, so I'm a biologist in a lab, so I'm not involved in the real world of this kind of stuff. As in the people making decisions, like doctors and vets both make decisions and who they give their, like, what do they prescribe and how much. So both of these groups get trained about antibiotic resistance in a kind of vague way, in that they don't see the immediate effects of it. They do see the immediate effects of someone that they're trying to help or an animal that they're trying to help right in front of them.
Yep.
But a vet compared to a doctor, like a doctor doesn't, so in the NHS or whatever, they don't have to think about so much the economic side, the other things that they have to take into account when they're trying to make their decision on what to prescribe or not, whereas a vet has these extra things you're saying. So do you think that these two groups would need different kinds of would be taking on the message of antibiotic resistance in different ways? And how do you help them both?
Yeah. Yes, that is $1 million question. Yeah.
Sorry, it's a really complicated question.
No, you're absolutely right. So one of the biggest problems with AMR, with antibiotic use, is this offset, this mismatch between I've got a sick patient, a sick cow, a sick child, a screaming parent who wants their child fit, whatever it might be. They're in the immediate emotional heat of the moment and they prescribe because they know that prescribing, even if it doesn't impact on the pathology, will make the parent feel better, will make the doctor feel better, will make the farmer feel better. There is such a psychological phenomenon that, like, doing nothing is harder than doing something, even if we think that something is not that useful, because doing nothing is really hard. And absolutely, it's a tragedy of the commons problem. You know, we misuse antibiotics because it helps us and it hurts society, but we're not society, we're us, and we're in that immediate moment. And then in terms of, so that is a massive problem. It's also what underpins climate change. There's the other thing is that, so the other part of your question, this thing around the context is different for doctors, particularly in the UK, where they are in the NHS system. There is a sense of economics, but much more removed than for vets or for doctors working in other systems where they are billing for the drugs they're using, for example. And so, in answer to your question, do we need different interventions? How do we help everybody? We do need different interventions, but we can learn from the different disciplines. And as a health psychologist coming at this problem, if I wanted to understand how to work with a group of people, whether that's GPs, junior doctors, dairy vets, you need to do the sort of exploratory work to understand, for this group of prescribers or this group of users, what are the barriers, and is it a lack of knowledge? 9 times out of 10 it's not knowledge. Is it social norms? Is it that there's prescribing norms in this particular hospital or this particular practice that are different? You know, have you got a lead senior vet or a lead doctor who is always prescribing critically important antibiotics? So you need to kind of understand what's the driving. Is it a social thing? Is it, is it that everybody wants to do the right thing, but it's an economic thing? And then tailor your intervention. And when it's about social norms, for example, or prescribing norms, a prescribing intervention in hospital setting can teach us something useful. because if we can change behaviour by intervening to change, say, social norms in a hospital setting, if that has the desired outcome on antibiotic prescribing in a hospital setting, we can say, well, that worked there. Let's tweak it and apply it in a veterinary setting and see if it works over there. But only if we think norms are a problem. So it's kind of two halves. What's the problem and how can we intervene to tackle that problem? And if the problem is the same in different settings, then maybe the interventions can be applied. But if the problem's different, if you think about, what drives disease in an affluent area of a developed country is different to what drives disease in an undeveloped country where they don't have access to sanitation. If I get a diarrhea disease, it's probably not because I'm sharing an open toilet. Do you know what I mean? It's probably because I've eaten something. Do you know what I mean? So it's about and so you would intervene differently with those things because the context is different. That answer your question?
Yeah, thank you.
No worries.
Interesting. Thank you.
Thanks.
I can't see any more hands up. I'll just give everyone a few seconds. But thank you again. So I think everyone got a lot out of that. But,
great. Thank you so much for inviting me. I hope it was useful and interesting for people. And
well, it definitely was for me. So
good.
Thank you.
So.
Great.
Yeah, like I said, cheers Sarah and cheers Claire for sharing. Great seminar.
No, you're welcome. That's fine. Thank you so much.
I'm definitely taking the phrase accidental academic away with me, by the way.
Definitely. Yeah, that is how I feel about it. I went through my entire PhD saying I'm not opposed to staying in academia, but I'm not opposed to leaving it either. Let's just see what happens, pretty much. Because then I didn't need to worry so much. Yeah.
Cool. Well, I need to fly because I have some cow poo that needs attending to. But if anybody does, any early career researchers have any questions for Sarah, do shoot them her way because she was a PhD student just like us not long ago. So
definitely,
she knows what that transition's like.
Yes, absolutely. So Claire Spreadbury, when she invited me, did say that if I could stay on to kind of just do and not any questions. That makes it sound very Radio 4. If you want to just ask me anything about PhD life or ECR life or whatever, then I'm happy to stay on for 20 minutes or so. If there's nothing to ask, that's also fine. I won't be offended. Thanks, Ryan. Good luck with your food. Bye.